So May 28th is our next training meeting, and that will be Dr. Larry Carter, who's works at both hospitals. She's going to talk about pediatric sepsis. What's that? Yes.
Oh, cool.
Yeah.
Sorry.
She's going to talk about pediatric sepsis, child abuse, and then have a PALS update for us, just some really good stuff. And John's going to have a HIPAA update for us. It'll be a longer meeting, really important. You want to just wait until Bob gets here, or anything about the new employees that we should talk about?
I guess we can just put it up right now that we're looking to hire 8 new basic EMTs. Start date is to be determined. We're going to start have 2 groups of 4 go through. Just a little bit of some training updates for that. We've switched from the 12 training rides, we're just doing 10 now. And doing an additional orientation day, and I know some people have already approached me, and we all hope we can get for those orientation days. So, as many people as want to help that be beneficial, that way one person will be a lot easier that way. But yeah, as of right now, we're just waiting for insurance checks and background checks, which take a little while, and then go from there. So.
Okay, thank you. Anybody have any questions about the new employees or any feedback? Okay, so a couple of things. On May 22nd, the Board of Regents for the university system is meeting in Great Falls, and we're going to be there, and that's when we'll know about the paramedic program. So by the time we have our next training meeting, we should have an answer. I think it's going to happen, if that's the word that they have, but if it does, it'll be a like we were talking about last training meeting, it'll be an AAS National Register whole deal 1.5-year program. We're working hard to get an official schedule out, but it will probably start in the fall of this year if we actually get approval. So that's something we should know more about then. Most likely, Bob will be in to talk about some radio operations when Mike is discussing some stuff. So we had a critical skills checkoff that many people came to at our last meeting, that I do need to have folks who didn't attend check in with me, and I'll meet with you and we'll go over those things. It's really important that you do that. So if you did not attend this critical skills checklist, checkoffs, please be in touch with me. I will meet with you when works for us. We're working a lot with City Fire right now, and Mike being the joint medical director for both organizations, and also with Rural Fire. I know you've been hearing this from me in particular for a few years now, but just on our protocols, and Mark has put a lot of time into this as well. We're shooting for June. Anything about that, Mike? You want to say, like?
Yeah, so the protocols all kind of getting reworked and put into a format that'll be easier for us to update, because that's a big logistical issue right now. Just because over the years, different types of documents got put together, kind of mishmash, and that's all being redone by hand. So you see the gal who's the computer guru for the city say thank you, because it's going to be a lot of work. And then we'll try and get all the updates in there, and there'll probably be need for some edits based on kind of feedback from everyone. So I encourage people to look through it, and if something's worded poorly or doesn't make sense or is missing, let us know so we can try and get that updated once it's out. So hopefully there'll be everyone, at least within the 3 big agencies, all on the same sheet relatively soon. So.
The actual checklist that we were using for a while have kind of fallen away a little bit. We do plan on using those at some point in the future, but without the protocols actually being finalized, we're not really in a good place to have it. So if you don't know what that even means, don't worry about it. But we have an app that was somewhat usable in the field for people who used iOSs, for used Apple phones and stuff. Yeah, it's still something that you'll see. But if you went through the trouble of getting those all loaded and have them, they're just not quite being used. And
that's still, I mean, that's a tool for you to remind yourself of stuff maybe on the way to things. Sometimes maybe at a scene, but really that's just kind of the idea for that is to have a tool for us to review our protocols that's quick and problem-based. And then hopefully we'll have that for critical skills as well. So like a step-by-step thing.
The link to the state protocols is not
Is broken.
up to date because they
Yeah, as we went from Ron Brunell to Dave Smith, some just, neither their fault, but that kind of didn't get carried over yet. So that's what's yeah. Okay, let's see here. Anybody have any questions about anything? So curious again, if we do run a medic program, how many folks might be interested in that? What is the interest out there? I'm so curious. I'm not looking for a commitment, I'm just looking for interest. See what it would be through the college and through Messi. All right, so I apologize. Last week I did have a death in the family and I could not make it here, so I believe, and so the person who's going to talk about some TBI stuff, Jasmine, might be in a little bit later tonight because she's actually on shift right now in the ICU. So I'm hoping that she'll make it here, and if she doesn't, then we'll probably be ending it a little bit earlier than otherwise. So we're going to get right to some of our new medicines that we're carrying and why we're carrying them. And just give us a second here as I load this up on the computer, okay?
All right, so let's get this started. All right, so we're going to have 3 new medications kind of available for our protocol. We're going to have a 3% saline for traumatic brain injury, Solumedrol for severe asthma and COPD, and it's still in the state protocol for adrenal insufficiency. And I didn't really go into that too much in the slides, but we can talk about it. And then magnesium for severe asthma and COPD as well. So 3% saline. So there used to be only mannitol as a medical intervention for increased intracranial pressure, but 3% saline is come into vogue and is used more and more for a number of reasons. There's good studies that show that it decreases the intracranial pressure and increases cerebral perfusion pressure in adults and in pediatric patients with severe traumatic brain injury. And there's the data is from kind of critical care medicine and pediatric critical care. There is actually some EMS studies on this. The EMS studies do not show tremendous benefit, just so everyone's aware. But it was pretty liberal use of the product. It really showed that the people who had traumatic brain injury that weren't bleeding to death did better, and the people who were going to die from their injuries maybe died a little bit faster. Just so everyone's aware that that's out there. You can look at those. That may impact how you decide to use or not use it, but there are some adverse reactions with it as well. So it can cause high sodiums. Most of the time that is not going to be a problem at the doses we're using. The chances of raising the sodium to a level that is significant is low. That's often if people are getting multiple boluses or even infusion over days where that becomes a problem. It can volume overload patients and make them hyperosmolar as well. That means that they have all this solute intravascularly. In people who have super low sodiums, there is a risk of demyelination, and that's where the raising the sodium quickly can cause problems. A lot of those studies were with a 7% sodium, however, and this is a much lower concentration. This amount of 3% saline would probably raise someone's sodium like 3 to 5 points, which for most people is not significant. Metabolic acidosis is a risk factor for this. It has a low pH, lower than normal saline. And there is some risk of rebound, increased intracranial pressure in up to 3% of some patients. So it's not totally without risks, and that's why we're going to try and restrict it to patients with really severe traumatic brain injury. So this is people who have a GCS less than 8. In the setting of traumatic brain injury is our only indication right now, so not for known subarachnoid that you're transferring, not without a medical direction would you be doing that, but so in the field with severe TBI, GCS less than 8, and then one other sign of increasing intracranial pressure. So abnormal pupils, I mean classically that's taught to be unequal pupils, the blown pupil on the side of the herniation, but that can be with pressure on the pons, that can be pinpoint pupils. It could be big dilated pupils that don't react. But so abnormal pupils, hemiplegia, so paralyzed on one side of the body, posturing. They used to make big distinctions between decorticate and decerebrate posturing, but some type of posturing, bad. Yeah.
Even transient, so if it's somebody else who had seen it and then you arrive and now the posturing is done, is that something that you would consider?
If their GCS is still less than 8 and they had that, I think that's reasonable. And it'd be true posturing, so extension posturing is turning the hand out, and it can be on one side, so turning out, and usually extension at the foot, and then decorticate is turning in and tight. Have people seen that? It's not terrible common. It's only goes on for a short period of time before really bad things happen. So, and by the time it's present, it may well be too late for some of this stuff. Not always, but. So Cushing's reflex, does everyone remember what Cushing's reflex is? So hypertension, bradycardia, and abnormal respiratory pattern. So those kind of things are thought to be our body's mechanism to try and maintain cerebral perfusion pressure in the setting of increasing intracranial pressure. So I put posturing twice apparently, I'm not sure why. So sorry. This today.
Hey Mike, can you go back and tell a little more about the pharmacology of what the 3% is doing for us?
Yeah, so mannitol works by increasing it's an osmotic diuretic, so it draws a bunch of fluid intravascularly and then our kidneys get rid of it. 3% saline does kind of the same thing, but it tends to cause less osmotic diuresis. It still increases your circulatory volume pretty significantly, so you will get increased urine outputs with it if you're taking care of the patient long enough to see that.
And is it more selective across the blood-brain barrier or anything like that, or is it
No.
drawing selectively from the
No. So there are other protective effects that are immunologic, they think. It affects immune cell function and may decrease oxidative damage to the brain by affecting how the immune cells that are associated with tissue damage work. So there's some neuroprotective effects outside of just the drawing fluid out of the brain. So it was in some animal studies it does dramatically better than mannitol because of those effects, they think. But in clinical practice, it's found to be less significant than we hope. So there's a big trend towards going to this because mannitol really tends to crystallize a lot, so it's hard to give. It does cause a lot of diuresis, and you can, especially in trauma patients, if you're worried about their volume status, can become a problem. In the setting of uncontrolled bleeding, though, it has the same drawbacks as mannitol. From that setting though, because you're increasing, circulatory volume and may increase blood pressure some, and that can, increase bleeding if there's uncontrolled hemorrhage. But this is it's a balancing act because if the brain doesn't survive, it doesn't matter about the other stuff. So I think
Mike, what do you think about burn patients or immunocompromised patients? If I have a TBI and a pretty significant burn,
you can still do it. So. They won't have renal injury for a while down the line,
right.
And they may need additional fluid resuscitation. But the best use of this will be like isolated severe traumatic brain injury. So That's going to be the best chance you got for this. If they have multiple trauma, like uncontrolled torso hemorrhage, internal bleeding, chances that this is going to be super helpful if they have a traumatic brain injury. It's not great, just so people are aware. Are there any questions about 3%? It's kind of something that's out there that's been used a lot. They're using it a lot more in the field, especially in the military. Is using it quite a bit. It's way easier to do than mannitol. The dosing is super simple. It's just a 250 milliliter bolus. That is on the low end, so everyone knows. A lot of places are using like a 500 bolus. So it does give us the ability to repeat that with online medical control. The additional bolus would be with online medical control, and that would be 30 minutes if they're not responding to that. So for a longer transfer, potentially. And then there's pediatric dosing, the 5 ml per kilogram. So
Are there any compatibility issues with anything else?
nothing that's not normal saline compatible. So it should have the same compatibility stuff. So is there anything else you can think of, Marcus, for that? I think it should be the same as normal saline stuff. So.
Don't try not to extravasate it.
Yeah.
Make sure it's a good ID.
It can cause some tissue damage, so that's good.
So would this be the fluid that we would be potentially trying to keep the patient permissively hypotensive? Like, is this, or should that
So
be
this is a different situation. This
Yeah.
is when you have a severe traumatic brain injury.
right? So if you had
Because in that
multi-
setting, we're not doing permissive hypotension because of how bad the outcomes are. So, even one blood pressure less than 90 corresponds to a really bad outcome. The other thing to be aware of is that this should not replace any of the important general traumatic brain injury stuff we're doing, which is ultimately as or maybe even more important. So keeping the head up 30 degrees, avoiding the tight cervical collars. Tight cervical collar, just so people know, dramatically increased intracranial pressure by restricting venous outflow. If someone does have a severe traumatic brain injury, that collar should be on super light. I think that once we have a legal basis for it, we'll probably be getting rid of cervical collars at some point, but unfortunately just the way that's medical legal community is right now, that's just not going to be an option. So.
Can I ask you a question about that? Because I came up with the,
Yeah.
like, particularly in terms of penetrating trauma, because that's where all our research is really best, right? Like,
Yeah.
can we just not? Can we
think-
at least move forward there? No.
I think it's pretty reasonable. I think that there are a lot of issues with it too in that setting. Not only the increased intracranial pressure, but you may restrict your access to control bleeding. So if you have to control bleeding and it's underneath the collar, it's not doing you any good. You can't use it like a tourniquet, so I guess you could, but don't. Because it's essentially working as a venous tourniquet on most of your patients. And it doesn't, for a lot of your patients, it just doesn't matter because they don't have this increased intracranial pressure problem. But it will cause that, so. Avoiding hyper and hypothermia, too, really important with traumatic brain injury. We don't have the ability to prophylax seizures, and the data is very mixed as to whether trying to prevent seizure actually improves the outcome, but certainly treating seizure, if it does happen, is really important. So avoiding all those things that cause secondary brain injury. So good positioning, very loose cervical collar, avoiding hypoxemia, avoiding hyperventilation or significant hypoventilation, and then last line is this kind of stuff. So we'll make sure we do all those other things.
So we're shooting for anti-idol is 35?
Yeah, so 35 to 45 is the kind of general range we want. 35 to 40, I'm sorry, is the general range they want for that. Transient hyperventilation would be used, probably not so much by us, because that's just really not been shown to be very effective in this transient term isn't really even defined by anyone. So I think where that might be useful is if you're transferring someone from community to St. Pat's who has a known epidural, subdural hematoma that needs to be evacuated. That's when you might consider that transient hyperventilation with a medical control. So
With signs of herniation.
no, that would be if they had known. So they have a space occupying bleed. They're getting emergently transferred. So that would be the setting where you might use that, I think.
I know you said it wasn't defined, but is that 20, is that to end title or is that to,
There's no,
That
so when you
100
look up
precedent?
where that data even came from, it's really nebulous, but looking to see what transient means in that setting is not, and there's no consensus from neurosurgical experts actually. So some people say, minutes, other people say, maybe a couple hours, but there's no data to support that. So, and actually, if you're hyperventilating for too long, even if you're in that range, that cerebral autoregulation changes in response to that, so the effect kind of goes away, and it differs in different patients as to when that effect changes. So, other things, 3%.
Mike,
Yeah, go ahead.
can you just talk through the multi-system trauma patient? They have a head injury.
So if you have a multi-system trauma patient who has like torso injury as well, or multiple extremity injuries and unknown torso injury, who is hypotensive but has evidence of severe traumatic brain injury, that person is probably not going to do very well, no matter what you do. The benefit of trying to keep their cerebral perfusion pressure up at the expense of increased bleeding, if you have short transport time, is probably there. Because if you're able to improve their cerebral perfusion, their chances of a good neurologic outcome are better. So,
What's the target pressure in that scenario? Hundreds of systoles?
so there's no data to really show what the target pressure is, but it's shown that if it's less than 90, for sure your outcomes are much worse. So.
Can we give TXA and 3% saline? Not together, but together.
I think that's reasonable. I mean, if they meet the criteria that we're using for TXA currently, and I suspect that our criteria will change in the near future. CRASH 3, which is the third iteration of the TXA trials, is currently, I think it's actually done now, and they're putting together the data. And the early look, from what I understand, is that there may be significant benefit in patients with traumatic brain injury as far as decreased bleeding into the brain and better neurologic outcomes. But I'm waiting to see what that actually looks like. So.
Should I add that 250 mil bolus to my resuscitation bolus? Just add my math together, or should I just call it separate?
Yeah. So the trauma, what is it called? ATLS has changed their fluid recommendations. Has everyone seen that? Do you know what the new fluid recommendations are for ATLS?
Blood products.
Yeah. So it says, they said restricting crystalloid fluids to 1 liter now. So that was the
That still doesn't mean give a liter.
That doesn't mean give a liter to every trauma patient, but that means if you're trying to maintain, a minimum blood pressure, your permissive hypotension, that you're going to only use up to a liter. So, and it's different because this is going to draw more fluid intravascularly. So 250 mils of 3% is what, that's about 1 point something liters of normal saline. 1.2, I think, is what they said, something like that. So yeah, that does change it, but you're doing it for a different reason. So because you're trying to preserve a neurologic outcome.
So if we have a bleeding head, we're suspecting head trauma, we give our TXA, can we give the 250, is this what you're asking? Give the 250 bolus and then like LR on top of that?
Then no other fluid outside.
No other, just
If you give,
Like a fluid challenge.
yeah, I would not
See.
give any additional fluid. And that is one of the confounding things with the big studies on this. In the pre-hospital studies, patients were receiving the hypertonic saline at 250 or 500 mils, and then they were getting like another 1.5 liters of crystalloid. So that probably negates a lot of your benefit. So, because what you're doing then is you're probably, instead of drawing fluid out of the brain, you're probably drawing fluid that you've given intravascularly back into the vascular space, because when you give normal saline, about 2/3 of that goes extravascular relatively quickly. So that you're probably shooting yourself in the foot by doing that, would be my guess.
So can I just follow up on this? Sorry. So if you gave your 250 and they're still hypotensive,
Then you could consider giving an additional bolus of like normal saline. Unless you're at that 30-minute mark where you want to consider online medical control to re-challenge. Realize if your pressure's low like that, that's it's all a balancing act with not very good things to balance.
So let me paint a different picture for you. You smush somebody's head, just the head, they're gonna have a high blood pressure because their body's trying to auto-regulate, okay? And they may be bradycardic. That's the patient that's gonna benefit maybe from 3% saline. The multi-system trauma probably doesn't matter.
Yeah. You could consider it, but our best bet's gonna be for patients with isolated head injury. So. Yeah.
You just said normal saline,
Or LR, whatever.
whatever.
It
Because
does
they're
not,
going to die anyway.
it does
Is
not
that what you're
matter.
saying?
There's never been a study that shows that one is better than the other. And there's
I just read
there's-
something about that both, but especially normal saline, contributes to overall mortality in trauma.
Probably, that's probably true. But I don't
So
think it'll
what is our permissive hypotension, and can we just not even do that if it's not included with a head injury?
Yeah, I think the standard right now, so everyone's aware the permissive hypotension came out of animal studies and then a study in Texas by this guy Bickel, and he looked at penetrating torso injuries, and he looked to see if patients would do better with minimum fluids or with standard therapy. And they found that minimal fluid was associated with better outcomes. And the conclusion isn't that hypotensive resuscitation is good. The conclusion of that study is really that crystalloid for trauma is bad. And that's for really penetrating torso injuries. So, and you can extrapolate that, I think, fairly to blunt traumatic injury from car accidents with bleeding as well, because it's the same mechanisms going on there. But that's where the whole permissive hypotension came from, was those studies. There's never been a good study to show what the optimum blood pressure is for hypotensive resuscitation. That has not been done. It's being done with blood if you have the ability to give blood right now. So they think that if you're able to give blood products, you don't want to do permissive hypotension. Because if you think about shock as a dose, like how much shock you can tolerate before it's irreversible, what your shock dose is, if you do permissive hypotension in someone and you have the ability to give blood products, you're probably unnecessarily increasing their shock dose. So it would be one way to think about that. And there's some data already that a blood pressure around 110 systolic was associated with better outcomes if you can resuscitate with blood products. So. We're not getting blood. Not yet.
So let's say that we have a known, like we're extricating or whatever, for some reason we're on scene for a long time. Is there any way to get blood products besides if we're far enough out to have like flight network?
The only way I know to do that right now is life flight.
There's no way to pull products from the hospital outside of the hospital.
I think if you called like the surgical team like they've done before, that would be an option. But that's about the only way I can think to do it. And I'm not sure the blood bank will release it. I don't know, I've never had that come up. And based on blood bank performance recently, I would say that it's pretty unlikely. I would like to see a time when we're able to start carrying blood. I think that'd be awesome. And the way some systems do that would be to have a supervisor vehicle that has a blood cooler, and but it requires a lot of paperwork. So it'd be awesome if that could be whole blood too. But yeah.
I know I texted you, Dave, about it, but I didn't find the response from you guys. But could we come up with a radius around the city? I haven't run a call. I mean, granted, I'm not running as many calls, but I haven't seen my flight network on a scene call for years, I think it's been. And I'm just wondering, like, where they're at in our EMS system, and then can we come up with something more formal for them to respond to traumas that aren't in Idaho necessarily? Because I feel like they do have a resource that could decrease mortality that isn't getting used, at least pre-hospital wise.
I think it was within 45, either 45 mile or 45 minute response time ground is as fast as air.
Right, but what I'm saying is that time frame doesn't matter as much if they're bringing a product to the scene as well. You know what I mean? Like, that's all we've ever based it off of is transport times. But we're not looking at them as like, hey, you have blood and we don't. Can we like use your blood?
I would think not.
Maybe they could have a little parachute and they could fly over and drop it.
It's like
Thank
Hunger
you,
Games.
doctor.
Hunger Games, you just send it out.
You could use your own.
I'm gonna request them then. Just so- Like if I run a trauma past Clinton, like,
But at what point are you better going to the hospital than waiting for blood?
yeah, I'm not saying wait on scene, but I'm saying like, no. The fact that the only request for them is once somebody's on scene,
Yeah.
within Missoula County and beyond, it never matters then. Because we're always gonna already be there and gonna be able to drive back by the time they launch and come. And I think that's a flaw in our system, and it would be I'm not saying they should auto launch like old life flight used to do on everything, but like, it's a weird.
Yeah, I don't know. It'd be hard to determine pre-arrival conditions that would do that. I mean, who knows? So, patients unconscious from trauma within half an hour. I don't know. That might be something to look at. But
Sorry. I just open for conversation while we're talking about head injuries and hemorrhagic and torso and cervical and hypotension. Would really love if we had a medication that we could give for pain for awake, hypotensive, multi-system patients, which might just be my recent forte. But I feel like we have nothing that people say you give ketamine. The board says, as in writing them, there's nothing we can
That's
give.
changed. That's right.
they did.
I just looked at the
I think they changed it.
protocols and there's nothing written for hypotension.
No, right, but it doesn't say that fentanyl must be first.
I don't see any pain med for hypotension and trauma.
Yeah. I
Am
think
wrong?
ketamine is a reasonable option in that setting because
You
you're.
have to call, which I'm happy
Yeah.
to do, but especially prolonged extrication sucks when you've got someone that's busted up and low.
I think that's probably
Just conversation.
for a number of reasons. That's probably the best way to go, to be honest. And now that the board says you don't have to give fentanyl first, I think that is a change we're going to make with these updates because the reason that's such a benefit is you can accidentally give 10 times the amount of ketamine and you're probably not going to hurt anyone. Whereas if you give, twice as much fentanyl as you're supposed to, you may significantly worsen outcome from a traumatic brain injury because they're hypoventilating now, or carbon dioxide's rising. You may have to do other measures to manage that. And fentanyl, while it's probably the most hemodynamically stable opioid that we have available, in patients who are super volume depleted, like from shock, from trauma, still will sometimes get hypotensive from it. So.
Why did you say we had to call for ketamine?
So to the board right now, we have no pain meds that we can give hypotensive patients.
Okay,
And I'm not
good.
trying to make their condition worse, but I've recently had like prolonged extrication, big eviscerations where it's just.
But is there a reason that we couldn't give analgesic dosing ketamine without an online med control order?
About that violating right now.
I don't,
In
I
the
don't think that's true.
I don't think you're right about that.
I'll look at it and look.
No, but I just don't, because because it isn't delineated that way doesn't mean that we can't do it, right?
I
That's a
feel like
question.
it's written for, I think it's written specifically for systolic greater than 100 is how it's written, but I can go get it and look.
But we should look
Because
because
it's a frustration. I mean, I just want to have the conversation, I don't want to get off
I
the
think-
ceiling.
it is what I would use. If someone's critically unstable, like say maybe they got shot in the chest by themselves, that person I would not give stuff to, unfortunately, because you might make them worse. So, but someone with a pressure of like 80, I think using ketamine is pretty reasonable actually, as a single agent even. So at analgesic dosing. So
Just something just to tween you, to get him out of a car.
yeah, we'll have to look at it and then we can update that with this because I think it is a good option. And the whole thing with it increasing intracranial pressure has really been debunked as not the case. There was concern that ketamine increased intracranial pressure and they really found that that's probably not true. So it was based on ocular pressures, I think. Brad, did you find it?
Did you find it?
And, I mean, can we restate this and say that in trauma, especially hypotensive patients, we should be giving ketamine, right? Because it does have some pathomimetic effects and it's gonna help with blood pressure. Is that wrong of me to think of it that way?
So it's interesting because there's, if they're not super hypotensive, do we want to do anything about that? Yeah, so their pressure is 90. Do we want to do anything about that, like give them fluid? No, probably not, so.
But
So we want to.
ketamine doesn't kill people.
Blood pressure less than 100, systolic, respiratory depression, active labor, closed head, sudden onset headache, altered mental status related to injury and or allergy.
See, I think that, I would disagree with that for a number of reasons. First of all, if you have a lady whose blood pressure is 90 and she breaks her hip, she's going to be pissed with you. Because you didn't give her anything for
Right.
pain. And that's her normal blood pressure. So I think that's way overly cautious.
And I'm happy to call.
Yeah.
Completely happy to. I don't want to make things worse.
Yeah. I think right now, because it's stated explicitly, the way we get around those things is online medical control. So it depends who you get as to how helpful that'll be. So.
Do the docs
But we need to
know,
do it. We need to be doing it more. So. Okay.
do the docs know that we're gonna be carrying this?
They do. We've talked about it in trauma, and then we're gonna at our next group meeting. It's gonna be up there. I haven't talked to the people at community yet, but so. All right. So we'll try and write this out into a little bit different format, so it's kind of easier. But this is just kind of it. The next one is Solumedrol. So steroids, super beneficial for people with severe asthma and severe COPD, especially severe COPD. Actually, there's a lot of data that shows that steroids decrease the hospital length of stay if they're admitted. There's data that show improvement in spirometry measures, so improved lung function. Interestingly, they really showed that there's no difference between oral and intravenous steroids for mortality, hospitalization, treatment failure, and relapse at 1 month, or a bunch of secondary outcomes that they've looked at. When the Cochrane database did a huge review of this. And there's actually some studies that show that patients who receive oral steroids for less severe exacerbations have a trend towards better outcomes with lower incidence of some of the side effects. So we put Solumedrol on here for people with severe asthma and COPD exacerbations, and we're going to have it for people with impending respiratory failure, or if they're already requiring non-invasive ventilation or intubation. Because those are the patients that really, in hospital-based practice or in EMS, would benefit from IV steroids. So people who are basically too sick to swallow a tablet. So steroids do a lot of things. They have Solumedrol in particular has the corticosteroid effect that is anti-inflammatory, and that's what we're trying to get out of this. So it can decrease the swelling in bronchioles, and it does have mineralocorticoid benefits as well, which means that it can cause fluid retention. That can be significant fluid retention. So a lot of people with COPD have right heart failure, and it can cause enough fluid retention that they're going to require IV diuresis with steroid use. So just to be aware that that is kind of an issue. The other big thing is that it can suppress your immune system. It has anti-inflammatory effects, but those are mediated through the immune system, and it can cause significant immune suppression. And then GI bleeding is something we kind of forget about, but with the older intravenous steroid dosing that they used to do in the hospital, there was up to a 20% risk of GI bleeding of some type, from all type of GI bleeding, but usually stress ulcer. So a lot of this kind of went away from IV dosing after they've kind of found that there was a lower incidence of these side effects with lower dosing. So that's kind of why we're not giving as much intravenous steroid. I mean, we used to give tons of IV steroid in the ER, and now I rarely do. So I'm really reserving it for these people with kind of respiratory failure, too sick to swallow a pill. That would be that's kind of a good measure that you should be using intravenous steroids.
Can you go back to the previous slide?
Yeah.
So, there's no difference between oral and IV. Is there a difference though in the onset of the effect?
No. So most of the steroid effect is mediated through like transcriptional events. So it has to rev up the cell machinery, and that takes like 4 to 6 hours. So the reason it'd be beneficial for people with severe stuff intravenously is we're getting it on board sooner, so that in the course of their hospitalization, it's not going to prevent them from getting admitted from the ER, but it probably will keep them in the ICU get them out of the ICU sooner, hopefully. So is the idea.
So you foresee this as a patient that's on CPAP with an inline, also with an IV given?
Yeah, I mean.
Solumedrol, that's kind of your.
Yeah, I think if you're doing continuous nebs and you haven't got to CPAP, that's someone getting continuous nebs is who I do this for. People that are on non-invasive for sure, and then obviously anyone who's innovative. So they've already failed. They're triple failure. So, the reason we're going to use Solumedrol, right? I've debated a lot about carrying 2 different steroids, but I'm trying to keep this simple right now. Is that if you do have someone who has a known history of adrenal insufficiency, Solumedrol is going to work better for that acutely, and that's in the state protocol as well for adrenal insufficiency. But it's going to work better because it has that mineralocorticoid effect. A lot of these patients will have like refractory hypotension when they're super sick, and that mineralocorticoid effect is what we're looking for. Dexamethasone, which is commonly carried in some systems, does not have that mineralocorticoid effect, and so it's really good for like pediatric asthma, but unfortunately it won't work as well for adrenal insufficiency. So it's kind of like a one-drug deal. And there might be other indications where with medical control they would want you to give this for specific stuff. So we're going to stick with just the one steroid right now. Dosing for it, so that comes in 125, I believe, right, Dave?
It's right there. It's in one of those yellow. Right.
Oh, right here. So that's
For the
So-
pediatric dosing, I'm sorry, do you want us to give this for, like, in the stead of Decadron for croupy kids?
Yeah, so it'd be for not for croup. I wouldn't do it. So even most croup kids in big respiratory distress, we're giving them like putting the IV in juice, and even if they have fairly significant respiratory distress, we're doing it orally. It's 125 milligrams in the vial. So the dose that looking at a bunch of these studies is the 60 to 80 milligrams intravenously, and so I'd like to stick with that 80 milligram dose. Higher doses do have more side effects. There's reasons we do those, but for the stuff we're doing, that actually is looking at the Cochrane data, that was like the most common dose that was used. So.
Mike, maybe you said this, but if they're already on a steroid, does that change their dose?
It does not, no. I mean, And there may be other reasons that it'd be a good idea to do this if they're already on steroids. So if they're on steroids and they have severe respiratory failure, they're probably going to need a higher dose. And the other reason is that they may be acutely ill from pneumonia and have some type of sepsis going on as well. And in that setting, they're probably relatively adrenally insufficient. So giving them a bigger intravenous dose would be helpful in that setting. So I put the pediatric dosing in there, and again, it'd be the same indications for pediatrics, so like severe respiratory distress right now. So any questions about Solumedrol?
Are there compatibility issues with this with anything else?
Not that I am aware of. I actually don't know of. I've always just given it as intravenous push when I've done it before. So
Is it, I haven't seen it in years. Does it need reconstituted?
So it does, and it has the diluent at the top, so you have to snap the vial and then agitate it. So it should be pretty easy to do.
The problem with that dose is going to be a little difficult to draw. Because
Yeah.
125 of them is a.
So I wasn't sure what we would get this for exactly, so
We used to give it all the time in Denver. It's a great drug. It's
yeah.
just-
I think doing half of it will
It's
get
all-
you close, and
Yeah.
that for our purposes,
What is
it's
it,
fine, so we can.
122?
I think it's 2 mLs. And it's
It is
kind of
two
bubbly, so
mLs.
Once you get it shaken up, it's a little bubbly for a bit. You have to kind of let it settle, or else you're just drawing bubbles. You actually leave the needle in, your filter needle, shake it, the needle kind of helps.
Oh, like the time?
Yeah.
So going back and forth through the filter needle.
Yeah, honestly, I usually just stuck my needle in after I squished it together and just shake it up for about 10-15 seconds, and then you can just redraw without having to pull your needle out, especially if you're bumping down the road, you don't have a sharp out.
So we could use, certainly we could do it as a half the vial, which is easy enough to do, 1 ml, which would be in that 60 to 80 range. So, any other questions about Solumedrol?
No, for spinal cord, that's not coming back.
No, it does not. I mean,
It's okay.
this neurosurgeons and steroid dosing, I don't know. So a lot of times, just they'll do Decadron, and they're doing like 4 milligrams Q 6 hours, and Decadron's half-life is like tremendous long. I don't know where that even comes from. So
I have a question on using a filter needle on that. Does it pass the drug back through the filter, or, we usually would use that for like a glass ampule, but I haven't ever thought of using it for.
I guess when I said filter, I mean just the red blunt tip is
The
what I
green
meant.
red.
Not
Okay.
filter.
'Cause,
Yeah.
Red packs.
Just your blunt tip.
Okay.
It's fine.
Ooh, too much short ones, let's go through that.
Yeah. Yeah, they'll go through.
You know what I mean, they have like the pinch ones and then they have.
Oh, yeah. I usually just use the.
Those aren't
I
solid
think
core
they're long.
rubber on there. It's just enough.
Mike, can you go back up one slide?
Oh, is it? Okay.
Oh, I know the one you're talking about. They're like double-sided.
Uh-huh.
Yeah, probably the single red one that's all red. Is probably the way to go. Yeah, you're right. Probably.
We used to carry this stuff for spinal dose.
I've used it
You do
forever.
not need a super long needle.
I like it better than Dex. Yeah. Dex gets the ants in the pants if you get it too fast.
Avoiding ants.
They like burning down there. Really bad. Don't ask me
any other questions?
I have questions when you get the mag, because that'll be.
Oh yeah, so for magnesium, magnesium would be adding kind of for the same indications basically. And magnesium works as a bronchodilator. It causes calcium influx in the smooth muscle and can relax bronchial tubes. There's good data that, man, my slides got all screwed up. I think this is my old presentation. There were 2 of them on my desktop, I'm sorry. I did one at work and then one that I did to reorganize it. Anyway, so it's been shown to decrease hospitalization, improve lung function in severe asthma. There's not really significant benefit using it nebulized. That was a question I've been asked a couple times, and nebulized magnesium has not been shown to be very effective. So we're going to use the same And indications, severe COPD and asthma refractory to multiple nebulizer treatments or impending or actual respiratory failure. And the dosing we'd be using is 2 grams over 15 minutes. It's less, there's some people who don't like it as much in pediatric patients, but the dosing is 25 milligrams per kilogram over 15 minutes as well. And I'd like to reserve that for medical control, so some people tell you no.
Can you just talk us through thinking one versus the other or both?
People who are like super sick, I'd be trying to do both of these. So I usually go to magnesium once I get in the continuous neb range. The other people you should start thinking about these things are people who have a history of intubation for asthma or COPD, because they're more likely to need a higher level of treatment for their acute exacerbations. But you should start, that's a good question to kind of sort out how bad someone's lung disease is if they've ever had to be hospitalized in the ICU or required intubation. So if they can talk to you.
Is this the 10% solution?
I think what does it come as? 10%, 50%?
It comes in 50 is what we carry, but
Yeah. So this is 5 per 10 ml. Yeah. So.
Are we going to be good to give this for eclampsia as well as like torsades?
Yeah, I think that thinking about using it in those settings is reasonable as well. Eclampsia is in the state protocol right now, I think, and I think it's the same dose.
I think it's still 2 grams. Yeah.
It's still 2 grams. So torsade, giving 2 grams of magnesium and torsade is also really reasonable. If they're in arrest, you don't have to do it over 10 minutes, obviously, but the reactions, hypermagnesemia. If you're giving a bunch of mag, that's more of a problem, but what would you look for in that? Does anyone know how that presents?
Sorry.
Anyone on
Say it
labor?
again.
High magnesium levels?
Their reflexes get poor and they alter and
Yeah.
somnolent.
The only time I've ever seen that is on labor and delivery, where they're on like mag infusions for eclampsia and stuff. So, and then it can cause some hypotension and vasodilation. So that seems to be pretty real. So I would definitely give it over the 15 minutes. So if it doesn't finish by the time you get to the hospital, that's fine, I think, in that setting. But I wouldn't stay on scene to give this. So there's a fire department back when I was still doing pre-hospital stuff, that they were on scene with this patient, and the ambulance was saying, hey, we need to get this guy loaded and get him going. He's like really doing poorly, and they're like, well, there's nothing that they can do at the ER that we can't do here. And every time you hear someone say that, it should make things go up because on your spine, because that usually means that someone is way overconfident. Because anyways, what happened was they were giving magnesium, doing all this stuff, and then the person respiratory arrested, and then they had a difficult intubation because they were in a system that could do RSI, and they had like 4 attempts, and the patient did not survive. So anyways.
Clarification, I think it was said it's 2 grams for eclamptic seizures, it's 4 grams.
It's 4 grams?
4 grams.
4 is what the state said.
Oh, that's good to know. So I did not.
Otherwise it's 4 to 6.
Okay. It doesn't say an infusion time.
Over 5 minutes.
So that's about 5 minutes.
I've never given mag for respers. What is the efficacy? I mean, is it a very quick turnaround? Is it noticeable?
Like you said, whenever I had the real, and see, since we don't have RSI here too, it's like, we gotta do everything we can. Like, Quentin had a guy the other day who was CPAP, and he was like circling the drain on CPAP. So I think that, because it's like smooth muscle relaxer as well, right, Doc? Like, it helps with the diaphragm and things like that.
I mean, it's gonna be working while it's infusing, but it's not gonna be, I haven't found the effect to be dramatic. That's been because they're already getting these big high dose bronchodilators. I think it's definitely a benefit, and I use it. there's a couple patients that I've used it on multiple times that come in. Listen, there's a guy who comes in who's kind of like heavy set with he always has like stubble, so the CPAP mask never fits him really well.
It's like every COPD patient.
It's not even
But I've probably given him
gender
mag like 4 times.
Being adventurous as well,
Oh, sure.
choose.
No dentures.
I
Solid.
think it's like the ones that are that sick, it's like, you know, pull out all the stops anyway, you know? Whether it's
Yeah, I just
this-
wondered what the kind of the turnaround, I mean, obviously we're
Yeah.
gonna do CPAP and breathing treatments and on and so forth, but I just wondered sort of,
Of all the times that I've given it, I've seen pretty decent turnaround within 3 to 5 minutes.
okay.
It's quick.
What about epinephrine?
Well, right now I think Epi's in there for. Is it still just for? Is it for pediatric only?
Croup, 0.5 milligram for croup.
Oh,
Are you
so you
talking
mean
about
nebulized Epi?
We're
1 in 1,000 still in there for,
For severe asthma.
yeah,
that's what
asthmatic non-responsive to albuterol. That's what it's worded as in the state.
So there are some people who probably have less benefit from albuterol. There's 2 kinds of albuterol in the solution there. There's the right-handed and left-handed L and D albuterol. And some people are prone to having kind of worse bronchospasm with it. So I think it's still reasonable to consider, especially if they can tell you that. You know, they're like, I use leave albuterol. Has anyone seen that? People who have leave albuterol? It's a lot more expensive. The pulmonologists I talked to have said that effect is pretty minimal, but there are some people who are on that. And I guess that's the only people I've ever done that for, because I haven't found that it's any better than albuterol. So I think giving subcutaneous or intramuscular epinephrine, I think I've only ever done that in kids. So
can I just kind of run this through my head? So we walk in, we know we're going to like a respiratory distress, and you walk in, you can tell right away this person looks like crap. They're struggling to breathe, their color's crappy, so we put them on the breathing treatment, set up CPAP. So then, we get them heading to the truck. So then we're gonna throw Solumedrol on and egg, or that's where you're gonna?
I would actually.
Okay,
I
so
think
you're
if you're
just gonna
getting to
throw
that
like-
point,
like-
yeah.
Ben said just throw everything at them. So even though it's like, you don't want to, sometimes the CPAP for our regular COPD or something
Yeah.
just turns them around.
Yeah.
It makes them feel better. Are we just going to wait, or we're just going to throw this on?
So how I would do that is I would be giving, neb initially while I'm setting up my CPAP, and then switch to the CPAP with inline neb, and I'd be giving steroid at that point.
Okay.
And then if I'm still having significant bronchospasm, I'd add the mag. That's how I do this usually. So.
And you were
That's
talking
the right
about
answer.
oral versus IV. Are we going to be carrying both? I don't
No,
know if that's the question.
The only reason we're giving IV in these patients is they're already doing so poorly that we're trying to shorten that window for them. So, but in general COPD people, I just barely ever give IV anymore, and there's pretty good data that
But you barely give IV what?
IV Solumedrol.
I thought you said that's what we're going to do.
No, I know, but I'm saying for moderate COPD, moderate asthma, I'm not using IV steroids at all anymore. So it's the only patients who are with that.
They just do something now, they're going to die.
Yeah.
Right, exactly.
If they're too sick where you look at them and there's no way this person can swallow a pill, that's the person you should be doing it for.
Also, just to clarify, and we'll have this written out, but you don't want mag nebulized, right?
No, I don't think there's any benefit to nebulized mag really. So. And I've seen some places do that, but it's really not been shown to be very effective. So.
Is there any place for either of these with pulmonary edema from HF?
No. Actually, there is a place for albuterol. Albuterol can help people mobilize pulmonary edema. There's concern that people have heart failure giving them nebs, but if they actually have pulmonary edema, it's not been shown to have an adverse. There's a huge VA study where they looked at these VA guys who were undifferentiated dyspnea, and if they had bronchospasm, they benefited from bronchodilator, regardless of whether it was asthma or heart failure. So.
And then just as a reminder on pulmonary edema, and just a question here, the state under EMT with medication endorsement, patient does not improve, where are we at? Sorry, so if pulmonary edema suspected and blood pressure is greater than 160/90, consider 3 consecutive sprays, which I assume also would be 3.3 sublingual tabs of nitroglycerin. Do you want us following the multiple doses at once in those hypertensive pulmonary conditions?
You know, there is good data that people who are hypertensive who have pulmonary edema, they often have flash pulmonary edema from a dramatically increased afterload, which causes sympathetic activation, worsening pulmonary edema, and worsening afterload problems. And nitro definitely will benefit those patients. And I think that we forget that a lot. So I'm a big fan of using nitrates for people with suspected pulmonary edema early. So.
How about though, saying the 3 and then at
Just
the
different.
basic?
Well, you're CPAPing them anyway, right? So I mean, you might get one on board and then they're on CPAP. So
Right.
Yeah, I'm not.
But this is saying
would not-
to give the 3.
I would not give someone 3
at
nitro
once.
tablets.
Yeah,
So
That's how it's written.
that's how it's written.
yeah, I would not be doing that. It says 3 sprays, right?
Yeah. It doesn't say it says for chest pain.
Yeah. So, because you're using nitro drip for that in the hospital, and the nitro drip is maybe what pulmonary edema. People start super low, and you actually want to titrate it up super fast. And 1 sublingual nitro is way higher dosing than the nitro drip we start at 10 even. It's it's about a single nitro pill is 40.
It's 400 mics over 5 minutes.
Yeah, but
so
it works
it's
out to about 40.
lot,
Right?
yeah.
So it's still pretty high dosing. So, but the way I thought that they're doing it is maybe I'm wrong, maybe I'm confused with it, but I thought that it was 1 tablet every 5 minutes.
Maybe for enough chest.
It's not the way it is for the
That's
hypertensive.
just
Maybe I'm thinking just
yes. Yeah.
I'll have to. I don't remember the oral nitrate dosing clearly, so I'll have to look and see. So.
And I just would ask. I mean, we went away from nitro spray a long time ago,
It's not
but it does leave you limited if you have someone on CPAP. You pretty much give them 1, and then you transition to CPAP, and that's it. If we had spray, it would let us be able to and then keep going with.
or the paste.
Yeah.
When Greg was involved more, sprays were discouraged for multiple patients in the field because of concern of cross-contamination when you're aerosolizing it right up on somebody's mouth. That you could, basically those things were supposed to be single use at that point, and they're phenomenally expensive to do for single patient. And so that's where we migrated back to tablets.
I thought it was just cost.
No, that was the biggest concern, is that it's multiple patients being used on. I mean, basically you should throw it away after you use it.
As opposed to fingering around multiple ones and putting them back in. And then,
You could wipe it down with a single wipe.
Wipe each tablet down.
yeah. Okay.
Yeah, you're supposed to shake those out, you're not supposed to.
Does it say that you put 3 sublingual tablets or 3
No, it
sprays?
just says
It
spray.
just says sprays? Yeah.
But it still says 3 sprays.
But a spray is supposed to be equivalent to 400 mics, right? It's supposed to be the same.
It's supposed to be the same. I hadn't thought about that for a while. There is a way to do it with tablets though, and I don't remember what it is offhand. I still think it's separated in time though.
And the state hypertension pulmonary data doesn't have any of that. It just doesn't.
I'll look it up and see if I can find that, because there is a way to do it with tablets and I don't remember it, so. Any other big questions about these things?
I mean, I've just taken the tablets and chewed them up and then made my own paste.
And baby bird it?
Yeah.
That only works if you're a woofer. You can't do that if you're not a woofer.
Did you get really lightheaded doing that? Did you get a cooking on?
I mean, I'm pretty much hypertensive all the time, so.
You gotta give it hard though, by hands.
Can we just, you're so articulate tonight. Airway management, head injured patients, and the lack of the ability to paralyze.
Yeah, it's difficult too, because the outcomes are not good, and some of the data has really shown that you're implementing RSI results in a worse traumatic brain injury outcomes, unfortunately. And I think that depending what happens with the state, if we are able to get an RSI program at some point, it would have to be a really dedicated program. And I don't know what people think, but it might be a program where you have, it'd be like an endorsement for paramedics. You'd have to have a specific program where you're have so many OR days a year and have to demonstrate proficiency.
Are they still advocating for lidocaine at all for reducing ICP with innovation and increased ICP?
So there's this, what you're referring to is this thing called the neuroprotective innovation, and the data on lidocaine is not very good. It's the data on fentanyl, pre-medicating with fentanyl, is actually a little bit better. And they think that, I remember when we used to do this, they would make us put the laryngoscope in after pre-medication, and we would spray the cords with lidocaine with a little nebulizer jet thing, and then we give the fentanyl while we're doing that, and then do it to try and mitigate that rise in ICP that happens with laryngoscopy. But I think that's largely gone out of favor. Using non-depolarizing drugs is probably better as well, like rocuronium over succinylcholine. So that's typically what I do, is I still give fentanyl in advance, like when I'm giving my sedative, and then I do rocuronium, so it's a non-depolarizing drug and you don't get the fasciculations like succinylcholine. So, but yeah, I think that's potentially going to be something we're doing, but it's going to be down the line, and we have to figure out how to best implement that. So I'm just concerned if we have too many providers who are doing that the experience is going to get diluted in the system so much that no one's going to get any good experience at it, and it'll just be difficult. So, and we're going to start looking at airway stuff. We'll start looking at all our airway management and breaking it down by, attempts and indications and all that, which I think will be really exciting to look at. So,
Can we, as far as where we're at right now though, patient that's anything other than completely flaccid, that you can open their mouth, but let's say still has a pain response or whatever. I've intubated those patients, and I probably shouldn't have. Maybe I should have. I don't know.
yeah, they've really shown that facilitated intubation is lower likelihood of success with a higher risk of complications even than RSI. Your laryngoscopic view with using sedatives without paralysis is usually not as good. The adverse effects are just as high as what my understanding is. So your success rate is lower with taking about the same risks.
Wouldn't the argument be better to be just intubate through the gag, and once your tube's confirmed with end tidal, then if you need to sedate, do it after?
The problem is, have you ever done that?
I haven't, no. Usually I just made them buck the
It
two.
sounds like a good idea. I did it one time, and it's kind of scarred me because they were like gagging and stuff and coughing, and I was like, I'm pretty sure their ICP would be worse at this point. It was for respiratory failure in someone I thought it was gonna.
Yeah, that's what I got it for. But I never sedated that after it.
Yeah.
Okay, so then.
It didn't work very good as the answer.
Yeah.
in my
In this-
experience.
In the spirit of that, what do you think about spitballing awake intubation with some posterior hurricane gel? I had a patient that could have used it on to smoke the
Yeah.
whole front of his face off,
Yeah.
which sucked. I mean, we made it, but there was really no, besides surgical airway on an awake-ish patient who's bleeding from the face that I can't leave supine.
Yeah, I think that's going to be a difficult thing to manage outside the hospital using any technique. And I think the thing we always forget is positioning patients on their side, which is super valid to do, even for transport. So, depending, how many providers you have to help manage that person, that may be the better part of valor. And that thing is,
We
so.
high tripod and sat face forward and was able to.
Yeah, so.
So then presence of trismus, and then presence of trismus with vomiting, just correct them.
I mean, I think that if they have trismus and they're vomiting, that you don't really have any good option, so.
And what about trismus, not really vomiting, but
10%.
which is more common, I think, in my experience, but like.
Drop the nasal tube, buddy, man. Go.
What are you asking?
I'm asking, do you want us to just go by like, oh, what I've always seen is like, well, their stats are like 90, so that's okay.
Yeah, I mean, you don't have a ton of options. You have like nasotracheal intubation, but there's not a lot of providers who have that skill level. I've only done like 3 of those ever, and I certainly don't feel super good at it. To optimally do that, you have to warm the endotracheal tube up in something so it's more malleable. In your partner. And the next option is really positioning, suctioning, and high flow oxygen, which I think that's what we've all done. And then if you don't have the ability to do RSI, you have to really decide whether you're going to take on a crike in that setting too, and it would just depend, I guess, what the situation is. You can't oxygenate that person, and they have trismus. Well, then you kind of have to, right? You don't have any other option. So I don't know that answers it, but those are your not good options that you have available.
So,
Okay.
yeah, if we want intubation, is the OR the best place, or do you guys still allow them in the ER? So I was told.
I got in trouble for doing it, letting someone do it in the ER.
That's what I was told.
Yeah, so I was told that I'm not supposed to do that.
So
So what I'm doing, and I've encouraged people, is like, if it's someone that we're gonna intubate right away, ask to stay and help. Because even if you're not doing it, there's things you can learn, and hopefully people are amenable to that. But I've certainly been trying to do that for folks when they come in, so.
Oh, can we still use the OR?
I think there's a way to do that. We'd have to set it up through the hospital, but we can do that. So the benefit of your OR experience is going to depend on your anesthesiologist. And I think if people are interested in doing that, I'm happy to help try and set that up with Dave. And what I'll do is we'll find the anesthesiologist that would be better if we're going to do that. So, because I don't want people to go to the OR and watch like 5 LMA cases that the anesthesiologist doesn't talk to you the whole time, which was some of my anesthesia rotation. So,
Thanks.
Can we just address 2 things as a crew here? One of the things is just if you're an ALS provider or a BLS provider and you're taking care of a patient on scene, and the patient gets an ALS intervention, it's hard to justify that ALS provider